Welcome to the deep dive. Today we're really digging into peripheral artery disease, PA for short, and something often linked to it, intermittent claudication or IC.
That's right.
Our goal here is pretty straightforward. We want to give you, whether you're a patient or maybe a caregiver, the understanding you need.
Uh-huh.
So you can feel, more confident talking things over with your doctor or your healthcare team.
Absolutely. And look, it's completely okay, very normal actually to feel anxious with a new diagnosis like this.
Mm-hmm.
But knowledge really is power here. Understanding what's going on is your best tool.
Okay, let's unpack this then. When we hear artery disease, I think, like most people think heart, right? But PAD is different. It's the legs.
Exactly. That's a really key distinction. PAD is basically when the arteries specifically in your legs get narrowed. Think of it like a garden hose getting kinked or maybe a pipe getting a bit clogged.
Okay, like a clogged pipe. Makes sense. And the IC part, that's the symptom.
Right. Intermittent claudication, IC. That's the muscle pain you feel. It could be calves, thighs, even your buttocks. The key thing is it reliably shows up when you're active, like walking, and then it eases off when you rest.
Why does that happen? The pain with activity.
It's because those narrowed arteries, the clogged pipes, just can't deliver enough oxygen-rich blood to your working muscles when they demand more. Rest lets the muscles recover because their demand drops.
So if someone's getting that kind of leg pain, predictable pain, how do doctors figure out if it's actually PAD? What's the first diagnostic step usually?
Often it starts with a really simple test. It's painless. It's called the Ankle Brachial Index, or ABI.
ABI.
Yeah, it just compares the blood pressure reading at your ankle with the one in your arm. If that ankle pressure is, say, 90% or less of your arm pressure, well, that's a pretty strong sign you might have PAD.
90% or less.
Exactly. But, the numbers are only part of it.
Yeah.
Your story, when the pain happens, what it feels like, that's actually crucial too.
Right? The personal experience matters. Now, something I know weighs heavily on people's minds is the fear of amputation. When you hear poor circulation, people worry. How big is that risk with IC?
That is such an important question. And it's a valid fear, definitely. But I really want to reassure you on this point. For most people whose main symptom is this intermittent claudication, this walking pain, the risk of needing a major amputation is exceedingly low.
Really? How low?
We're talking less than 1% per year. It's very uncommon for IC alone. So our main focus in treatment isn't really preventing amputation, because it's already rare. It's about improving your quality of life, helping you walk better, do more.
Okay, that's incredibly reassuring, less than 1%. So if the big worry isn't amputation for most, what are the best ways to manage IC and just feel better day to day?
Right, and this is where you, the patient, have a huge amount of control. These non-invasive strategies, they're powerful. They're the first line.
Okay.
And the most impactful thing, truly, hands down. If you smoke, stopping smoking makes the biggest difference.
Right. Smoking is key. What else?
Beyond that, it's about overall heart health. So taking statins, those are common medications for cholesterol that also protect arteries. Controlling blood pressure is vital. If you have diabetes, making sure it's managed really well. And usually an antiplatelet medication, something like a daily aspirin, to help prevent blood clots. That's standard too.
Okay, so medications play a role, but you mentioned the patient having control. What about things I can actively do myself? Is there a standout non-medication approach?
Yes, absolutely. The real cornerstone of treating intermittent claudication is exercise therapy, specifically walking.
Exercise. Okay, walking. How does that work? Just walk more.
It's a bit more structured than that, ideally. We're talking about dedicated walking programs,
Yeah.
usually aiming for, say, over 6 months, doing it 3 or more times a week for at least 30 minutes each time.
And how hard should you walk?
This is the interesting part. The recommendation is to walk to the point of nearly maximal pain.
Wow, okay. Walk into the pain. That sounds tough. And maybe counterintuitive.
It really does sound counterintuitive. But pushing to that point of discomfort, then resting briefly, then walking again, that cycle actually encourages your body to adapt. It can even help develop tiny new blood vessels, like natural bypasses around the blockages.
Huh. So the discomfort actually signals the body to improve things.
Precisely. And here's something else really important. When we look at the evidence just for improving walking distance in IC, there's actually no compelling data showing that procedures like angioplasty or stents are better than a good supervised exercise program.
Wait, really? Exercise can be as good as or better than getting a stent for walking pain?
For improving walking distance in IC, yes. Consistent, structured exercise often leads to better long-term walking improvement. Your own effort can be incredibly powerful medicine here.
That's kind of amazing. So when do doctors consider those more invasive things like angioplasty or bypass surgery?
Good question. Those interventions definitely have a role, but it's typically reserved for situations where the IC is causing significant, really life-limiting disability. And critically, it's usually after you've given the non-invasive things, especially a solid 6-month trial of exercise therapy, a really good try, and they haven't been enough.
So not for mild pain or just because the artery looks narrowed on a scan?
Exactly. It's not generally for mild symptoms or just trying to prevent future problems. The decision is very personalized, often guided by imaging, but it's driven by how much the symptoms are impacting your daily function after trying other things first.
And I guess even if someone does need a procedure, the lifestyle stuff doesn't stop, right?
Absolutely not. That aggressive medical therapy, the antiplatelets, the statins, blood pressure control, diabetes management, and definitely not smoking, that all continues. Always. It's crucial for long-term success.
Makes sense. It's an ongoing process.
It is. And after an intervention, we mainly keep track by listening to your symptoms. Are you walking better? And checking that ABI measurement again sometimes. Interestingly, some narrowing that might reappear in a treated vessel can sometimes even get better on its own over time without needing another procedure.
So wrapping this up, what's the big takeaway for someone listening, maybe feeling overwhelmed by a PAD or IC diagnosis?
I think the main message is this. You now have a better understanding of what's happening. PAD is narrowed leg arteries. IC is that activity-related pain.
Right.
The risk of amputation from IC alone is very low. And you have powerful tools, especially stopping smoking and consistent exercise, that are often the best first steps.
Use this knowledge.
Exactly. Use this to talk openly with your doctor. Ask questions. Be proactive. Talk about your goals for daily life and work together on the best path for you. Managing this is a partnership, and your active role, especially with exercise, is probably the single most important factor for improving your walking and your long-term health.